Well, good afternoon. Welcome to the Summer TNS Conference. My name is Dr. Katie Henley. I'm a neurologist in Lubbock, Texas, and the current president of Texas Neurological Society, and we're excited for a great meeting here at a beautiful location. So I'm going to start by introducing our first speaker, Dr. Sheikh. We're excited. He's also the co-education chair for this summer conference, along with Dr. Trivedi, who's here in the front row as well. So Dr. Sheikh is assistant professor in the Department of Neurology, Division of Epilepsy at the University of Texas Southwestern Medical Center in Dallas, Texas. He serves as the director for the Adult Tuberous Sclerosis Program and Transitional Care Epilepsy Program. He did his medical school in Hangzhou, China, neurology residency at the University of Toledo in Toledo, Ohio, and a clinical neurophysiology and epilepsy fellowship at Massachusetts General Hospital, Harvard Medical School. He is a member of the Quality Informatics Subcommittee of the AAN, where he explores and educates members on the use of new technologies such as AI, machine learning, and natural language processing in quality improvements for neurological care. He also serves as an associate editor for the Epileptic Disorders Journal and is the assistant program director for the Epileptic Disorders Journal Internship Program. So thank you, and please help me welcome Dr. Sheikh.
Hello. Welcome, everyone. So nice to see everyone out here. Today we're going to talk about something that's pretty much familiar to mostly everyone in this room. Raise your hand if you guys have heard of artificial intelligence before. Okay. Raise your hands if you guys are using some form of AI or AI-based platform in either your personal use or your clinical practice. Okay, great. So implementing artificial intelligence in neurology clinic practice is an up-and-coming area, and there's been a lot more scope and a lot more outlook into this, especially on best practices and policies to look out for. So in this, we're going to talk about basic use cases and limitations towards practical implementation for artificial intelligence. A couple of disclosures. DAX Copilot and UT Southwestern do have a collaboration. It's in its launch program and now in its maintenance phase. Also, I do artificial intelligence work for the Quality Informatics Subcommittee of the American Academy of Neurology. All right, so here's a brief outline. One, we're going to talk about why is this important? Why do we care? AI, why should I care? We're going to talk about some brief technical considerations, which will hopefully shed light onto its potential use cases, as well as to some limitations and challenges to implementation. Finally, we're going to conclude. All right, so why should I care? Why is artificial intelligence so important to me? Listen, I'm a community-based neurologist. I do paper records. I don't need to know this. Well, a lot of your patients will have a brief understanding of AI, and more importantly, burnout. Everyone is familiar with this concept. Neurology burnout rates are among the highest specialties with the highest burnout. 60% of neurologists have at least one symptom of burnout per year. 61% of neurologists specializing in epilepsy, who treat patients with refractory epilepsy, have at least one indicator of burnout. And there's a ton of literature to show just how affected our neurology colleagues are to burnout. So, more studies here to show how burnout rates are growing, not only amongst neurologists, but amongst other medical subspecialists. What can we do? Is there anything that can be done in this day and age to help streamline and make our clinical practice more efficient, to help decrease burnout? Well, there was a survey done by the American Medical Association in 2023, which assesses physician standpoints to the biggest opportunity of areas for which artificial intelligence can be used in healthcare systems. And they found that around 56% can be used to address administrative burden. And then the survey also just assessed how many physicians were utilizing artificial intelligence currently in their practice. And about 14% were using them for discharge instructions and progress notes. So the American Academy of Neurology, we looked into this, and we explored just how useful AI would be towards implementation with our own practice. And these are two groundbreaking papers, and one of the earliest ones out there, that really explore AI, ambient technology, into neurology workflow, as well as other forms of AI-based models into neurology clinical practice. So before we begin into our use cases and talk about some technical limitations, I want to talk about some technical considerations. I think a good way of understanding what AI is able to do is fundamental in its understanding of what the technical aspects are. Now, not to get everyone super bogged down, this is not an engineering conference. We're just going to touch briefly. So, artificial intelligence is an umbrella term. And underneath there, you have machine learning, you have natural language processing systems. This is one we all know about. ChatGPT, Perplexity, Claude, DeepSeek R1. Then you have your vision AI models, your speech AI models. DAX Copilot is one of them. Dragon is one of them. And then you have robotics and planning as well. And when we talk about machine learning, we're talking about more higher, deeper learning, supervised and both unsupervised. When we talk about natural language processing, this is content extraction, classification. This can be machine translation, question answering, and text generation. So these are some more definitions. I will refer to some of these definitions in the upcoming slides. We talk about artificial intelligence. This is a computer or machine that performs tasks that typically require human intelligence. It simulates human cognitive processes, data analyzation, predictive tools, interactive interface, and conversational decision-making processes. Natural language processing, or NLP for short, is the application of deep learning which enables computers to process and analyze text into spoken words. And then ambient technology, or ambient intelligence, this is technology that creates an electronic environment within the atmosphere and allows for the detection of sensitive information as well as other technical or medical information, and then it interprets that response and then it generates textual data afterwards. So, how are the clinical implications of these models right now? Large language models currently are used to analyze and interpret unstructured medical text data, such as electronic health records, notes, extract valuable insights for diagnosis, treatment planning, and medical research. Ambient intelligence, these are clinical devices that are embedded within a physician-patient interaction setting. It automates the clinical encounter and summarizes content. Machine learning is currently being used via algorithms that are being trained to recognize patterns in clinical data sets that make predictions, algorithms, which can assess disease diagnosis, prognosis, treatment, and even patient monitoring. So how does it work? Well, you have all this data, whether it's structured text, voice data, 3D signals, imaging, all this data is put into an algorithm-based AI computer software. It undergoes training. Then, through a series of adaptation or recall, we're able to extract from this model information, instructions, object recognition, image captioning, Q&A responses, and even sentiment analysis. So a model's output is just as good as a model's input. And I'm going to talk about why that is going to be very important for later on. Before I do, let's talk about some use cases. What are some use cases that neurology providers are using AI for nowadays? One that we are all becoming more and more familiar with is its use in clinical documentation, where a majority of our workflow limitation resides at, where most of our burnout resides at. Ambient technology and clinical documentation efficiency. AI-powered speech recognition systems can transcribe clinician-patient interactions and convert them into structured text, which facilitates accurate and timely documentation of neurological assessments and treatment plans. There are a lot of products out there. Some of them include Augmetics, Dolby Speech, Otter AI, DAX Copilot. How does it work? You have me and a patient sitting in a room, as we typically would. Then this AI-based model, which typically is incorporated within your electronic health record system. For example, at UT Southwestern, DAX Copilot is integrated within the Epic EMR system. So, and I open up my Haiku app in my Epic. I go into a patient's chart of the clinical encounter. I press the DAX Copilot button, and I sit down in front of the patient. I take consent, make sure that the patient understands that this conversation is going to be recorded through an AI-based platform, and then it's going to be translated over through this AI-based platform into a clinical document for my review, which I do typically always review the patient's records afterwards, just to make sure there's no errors or fabrication. So after I get consent, I push the start recording button and I have a normal conversation with my patient. History, physical examination, discussion, and then the plan. After our conversation is done, I press stop recording, I end the encounter, greet the patient out of the room, and then I go back to my note. Open up my Epic tab on my computer, and I see that the note is automatically done. Subjective, objective, assessment, plan. Now, it is very important that it's quality reviewed. There is a human-in-the-loop model to make sure there's no errors in knowledge, no fabrication, and then I make sure all the T's are crossed, all the I's are dotted, and then that's it. I sign it. Done. AI is also being used for workflow optimization in terms of helping generate novel methods to create clinical decision support systems, scheduling patients, predicting patient behaviors, such as those patients who may cancel same day or even predict patient no-shows, can even determine wait time at an office. Additionally, it can be used as a protocol aid, flagging incorrect orders, enforcement appropriateness criteria, as well as accuracy of coding, enhancing reporting of communication and automated population of structured reports. EEG interpretation. We all know EEGs are ubiquitously used in neurology clinical practice. Now, a lot of us may not be EEG experts and may have some general understanding or knowledge of how to read EEGs from our training days. There is a machine learning-based platform now integrated within Natus, or the newer versions of Natus, which allows for a validated AI model to standardize computer-based organizing reporting of EEG and artificial intelligence, otherwise known as SCORE AI. This is able to distinguish between abnormal and normal EEG and classify abnormal EEG into categories relevant for clinical decision-making. It has achieved, in this study, shown it achieved human-level expert in performance and fully automated interpretation of routine EEGs. Application may thus far improve diagnosis and patient care in underserved areas and improve efficiency, consistency in specialized epilepsy centers. So if you're a community-based provider and it's been a long time since you've done some routine EEGs, and you can have an automated version of this system in your clinical practice, which is able to help distinguish normal versus abnormal. Now, there's a limitation in that that's all it can do. And then with the human-in-the-loop model, you would go back in and you would figure out, okay, this is abnormal, what type of abnormality is present, and then make a clinical decision that way. Other uses for neurology clinical practice is its ability for clinical research in terms of literature review and knowledge synthesis, in terms of generating graphical representation, graphical analysis, and even qualitative and quantitative data analysis, as well as transcription of manuscripts from one language to another language. Now, with some AI-based platforms, you can plug in an entire manuscript, attach it as a PDF file, and through prompt engineering techniques, ask it to summarize it for you. And if the language is too complex, you can ask it through various prompt engineering techniques to simplify the language or simplify the manuscript and summarize it at a high school level vocabulary. These are basically a list of various different types of AI-based models that are actually online and free for public use, that include things for for documentation, for literature review, for designing, for music creation, for video generation. All right, another use case is for neuroradiology. AI is being used to identify urgent findings that enable workflow prioritization of abnormalities such as intracranial hemorrhage, strokes, aneurysms, and even TBI, a non-contrast CT head. It's being used for disease quantification as well for patients with multiple sclerosis, assessing tumor volume and intracranial neoplasms, and identification of brain mets. It's also being used in stroke, incorporating artificial intelligence in stroke management. This is an interesting article which came out pretty recently, where machine learning algorithms are being developed to provide automated assessment of hematoma expansion and perihematomal edema in people with intracranial hemorrhage. These AI tools have been used to identify large vessel occlusion, which, as we all know, is responsible for a significant amount of ischemic strokes from CT angiography. So how does it work? Well, there's input of data. First, patient's data is inputted into this AI-based platform, along with a clinical picture of the patient's phenotypic expression, whether it's face, eye, or limb. And then this model is able to extract certain features that will determine severity on the NIH stroke scale, whether there's a facial droop, whether there's an arm drift, whether there's a leg drift. And then it analyzes, and then there's the output of data, results either abnormal, normal, evidence of either spatial evidence or temporal evidence. All right, so those are some brief use cases. How many of us are ready to use AI right now? Well, let's talk about some limitations. Safety. Big one is safety. Natural language processing and large language models can combine plausible words to yield confabulation. Inaccuracies can affect crucial medical information and treatment plans. Not only that, but you can get vague and generalized responses. This is an example right here. This is from ChatGPT OpenAI. This is taken from our paper that we had studied in 2023. On the top left, you could see that there is a partially dangerous advice that's coming from OpenAI. We asked the question, what is the first-line drug to use in a 25-year-old female patient who is in her reproductive age years and is planning on pregnancy and has just been diagnosed with juvenile myoclonic epilepsy? So we plugged that question in, and then we got a response. We said, or at least AI said, that the drug of choice is valproic acid. Does sound right? I mean, it is technically used to treat JME, but is it the first-line drug that I would recommend in a 25-year-old patient, a female at that, in a reproductive age? Probably not. There are better choices out there, like levetiracetam, lamotrigine. Why not consider that as first line? All right, on the bottom right, there's a vague and inappropriate advice. All right, how to surgically treat a patient with focal epilepsy with onset in the right mesial temporal region if they do not want surgery. All right, let's see how OpenAI did. Well, continuing medical management. Okay, that sounds reasonable, obviously. All right. Non-invasive therapies, all right, such as neuromodulation techniques, vagal nerve stimulation, transcranial magnetic stimulation. Doesn't sound right. As an epileptologist, and maybe some of you guys in the audience are practicing epileptologists or see patients with epilepsy, yes, we do use responsive nerve stimulation. Yes, we do use vagal nerve stimulation. But transcranial magnetic stimulation is not often used for the treatment of medically refractory epilepsy. Typically, we use deep brain stimulator. And it's interesting how this OpenAI did not recommend deep brain stimulator. And to say the least, it also recommended psychotherapy. So psychotherapy to use to treat epilepsy, that's also a little bit unusual. Though, to be fully transparent, it does say to treat the symptoms such as depression, which kind of makes sense. But I think treating the epilepsy is probably more warranted. Obviously, both of these answers do come with a disclaimer at the bottom that do not take the advice of OpenAI too seriously and consider expert opinion through a board-certified neurologist. All right. Another limitation is data quality, variability, and security. Remember back from that model I showed? AI's output is just as good as the input. So what if your data that you're inputting to train your AI model is coming at biased, it's inaccurate, it's not inclusive, it's not demographically expansive, it's not heterogeneous? What type of output do you think we're going to get? We're going to get an output that is equally as biased, as non-heterogeneous, as not expansive, not inclusive. Inaccurate or incomplete data can affect the performance of machine learning models and algorithms as well as natural language processing systems. Data security and violation of data privacy laws must be taken into consideration before these models are widely acceptable and used within clinical practice. AI algorithms should operate at an end-to-end encryption and HIPAA-compliant system. We talked about a little bit about discrimination bias amongst AI models. Not all AI models are created equally. Now there's more than 10 to 50 AI models out there. Only a handful of them have been validated to be used for clinical practice, open evidence being one of them. AI models generate bias that are present in the training data set. Usage of diverse data sets can mitigate this potential limitation. Other things that can be considered or other things that can be used to mitigate such limitations: employ a team of programmers that are coming from heterogeneous, diverse backgrounds, with different perspectives, different cultures, different genders, races, and ethnicities. This is how you get data trained that is non-biased and very heterogeneous. Have medical teams and governing bodies evaluate the AI medical findings before guiding decisions. Can AI replace humans? I think not yet. But I think what can happen, at least now, is there should be a balance between automation and human oversight. I don't think we're at the level where we need to be to have AI operate at a human out-of-the-loop model. So, talk about human in the loop, we talk about human out of the loop. Human in the loop, just as it implies, is where there's actual human, or in this case a neurologist, in the loop with every aspect to the AI's output. So there is cross-checking, fact-checking of all the model's output. All right? Humans play an active role in the development, in the training, and operation of the large language model system. Humans provide labeled data, domain expertise, and real-time feedback to help guide and refine the large language model's performance. Continuous feedback loop is very important to make sure that there is a consistent, accurate output of data coming from the AI. Now, and to give a brief story, in our practice, we have used DAX Copilot, and in the early phases with this ambient technology, I found many areas of fabrication, hallucinations, and errors in knowledge. However, through constant feedback through the DAX Copilot team, through the engineers, through the program engineers, is when I got a more accurate representation of my interaction with the patient. That would not have been possible if I did not provide that feedback. So if we are in a local area or a community-based setting and we are interested in implementing some of these technologies, having a close collaboration with your AI vendors, with some program engineering, program software engineering, as well as your prompt engineers, is crucial to make sure that the output of data is equally as reliable as doing it independently. And to briefly state, human out of the loop is where basically the large language model operates independently with minimal to no human oversight or intervention. Humans may have designed the initial system parameters, but the large language model makes predictions and takes actions autonomously based on the training data and programming. I do not think we're at the stage yet of a human out-of-the-loop model, and I do not think that we should be practicing at a human out-of-the-loop model level. So another challenge, as I stated briefly, is fabrication, errors in knowledge, faulty logic, memorization. Fabrication, hallucinations, this is when large language models invent something that's not in the data. Errors in knowledge is when the large language model offers something that is actually incorrect. Faulty logic is when large language models thinks or links ideas together incorrectly. Memorization is when large language models repeats verbatim phrases from the training data and repeating data from previous patients or data sets. I'm going to give you guys examples now of what some of these fabrications, hallucinations, and errors in knowledge look like from our experience. This is a paper that we published recently. It's Ambient Intelligence and Epilepsy Clinical Practice. On the left side of the table is a true patient history. This is from the early days when, through constant training of the model, this is before the accurate training was done. So this is in the first couple of weeks of the ambient and technology implementation within my practice at least. So, for example, we'll take the first three just to be brief. The true patient history was the patient started to have seizures at the age of 32. Okay? The ambient intelligence model documentation translated as patient seizures started 32 years ago. See where there may be a little bit of a difference. Second example, patient had a fall and hit his elbow. That is the true patient's history. The ambient intelligence model took this as patient hit his mother's elbow. That's not correct. All right? And lastly, we'll just pick one over here. Patient was previously on Briviact. Okay? For epilepsy, that's important. Briviact is a seizure medication, also known as a brivaracetam. However, the ambient intelligence model translated as, or took it as, patient was previously on rivastigmine. That doesn't sound like an epilepsy drug. All right, here is an example of errors by the AI model related to clinical reasoning. On the left is an example, and on the right is the type of error that it took. Basically, there were errors in decontextualization, errors in omission, and even contradiction. For example, the AI model incorrectly documented he attempted to consciously unconscious during the shower. That sounds very unusual. All right, another limitation is cost. Implementing and maintaining advanced technologies can be resource intensive. You're not only paying for your DAX Copilot, you are paying for the engineers behind it. You're paying for the constant maintenance of that program. Device and data updates, software updates, you're paying for that. The various prompt engineering and resources that are going into creating an accurate, non-biased output. And not only that, but your informatics team, you're paying for them too, their time. So at the American Academy of Neurology, there are 5 things to consider before integrating generative AI platforms or large language models in clinical practice. First is to define the problem that you want generative AI large language models to solve. What is the barrier that's in your clinical practice right now? Is it documentation? Is it patient follow-up? Is it patient no-shows? Then understand the AI model's limitation. What can it do? What can it not do? And this has to be fully transparent from the vendors that you're speaking to. Ask them, I want to do X, Y, Z. Can the model do this for me? Third thing is to consider the barriers. Are there any barriers in your clinical practice that would hinder its successful implementation? Do you have frequent Wi-Fi outages? Are you running on a Windows 95 operating system? This won't work. 4, review the compliance. Constantly review whether or not compliance settings are met. Constantly review if there's data updates and software updates. Constantly review new legislation about AI and where it's at right now. And then 5, consider silent pilot. This is what we did at UT Southwestern. We had a silent pilot with only a handful of people being allowed access to DAX Copilot. And after various meetings with our CMIO and our neurology informatics officer is how we were able to successfully implement now what is the maintenance phase. And I'd like to say that we have quite a few people now who are eagerly asking for ambient technology to be used at our institution. So, conclusion, consider clinical challenges prior to AI implementation, especially in our practice, whether it's private, academics, or private and academic. And obviously more studies are needed on the validation of AI models within neurological practice prior to implementation. All right, these are some additional resources. If any of you guys would like to get involved with the AI and Quality Informatics Subcommittee, please do reach out. We've also had some successful neurobites as well as updated manuscripts and new literature and new training sources out there now. Now you guys can go to American Academy of Neurology /AAN.com/artificial intelligence, and there's a page that came up with a lot of cool resources to look at for your understanding and education for AI. All right, thank you. Any questions? Questions? Great, everyone's an AI expert. All right, thanks.